All right, this is a review over the immune system. So we know there's an innate and an adaptive immune system. So innate means we are born with it. Adaptive means this is developed after exposure to pathogens, whether naturally in the environment or artificially via vaccines. So we'll give this as an example and run it through the whole thing. So to the left, we got a barrier. It's your skin. Let's say we have a wound. Let's say it's a post-surgical wound from a knee replacement or a ACL repair or whatever. You have a surgical wound dehiscence, you get an infection, and you've got methicillin-resistant Staphylococcus aureus enter the wound. Now, again, your immune system reacts to all kinds of things, not just necessarily infections and not just bacterial infections, but we'll use a bacterial infection in this case as an easy example. So methicillin-resistant Staphylococcus aureus bacteria enters the wound, colonizes it, and then this turns into an infection. So it is damaging cells. So it's releasing toxins and damaging all the cells. So in this case, let's say it's our dermis. There's fibroblasts, and it gets into the fat layer. It's damaging fascia, fat, even into the muscle, and it's damaging tissue. So this tissue damage is going to stimulate something, a couple things. First, you're going to release of all these cytokines into the blood. That's one thing that's going to happen. And these damaged cells are going to release phospholipids. Remember, cell membranes are phospholipid bilayer. Some of those phospholipids are going to get converted into arachidonic acid via an enzyme called phospholipase A2. It's the same enzyme that's blocked by corticosteroids. Now, arachidonic acid is formed from that conversion. Arachidonic acid can then be converted to leukotrienes by a lipoxygenase enzyme or prostaglandins and thromboxanes through the cyclooxygenase pathway, which there's a COX-1 and COX-2. NSAIDs, or non-steroidal anti-inflammatory drugs, block the COX pathways. Now, what's the point of that? So there's a bunch of leukotrienes, multiple prostaglandins that have varying effects throughout the body. We're just referring to inflammation and the immune system in this case. So in regards to the inflammation, these compounds are going to cause two things. On the left, I've written there vasodilation, which leads to the erythema and warmth. So if you do have a bacterial infection or skin and soft tissue infection where you can see the skin, well, you're going to see redness and you're going to feel some warmth there. It's due to the vasodilation, and you're going to have increased capillary permeability, which is probably the most important thing, and that leads to the edema you get with inflammation. So, why do we have increased capillary permeability? That sets up the next step. Well, we know capillaries, there's a single layer of endothelial cells, and large proteins like albumin, red blood cells, white blood cells do not leave the capillaries. But in this case, I drew bigger spaces there because the endothelial cells actually constrict and get tighter, or I should say get smaller, so they create bigger spaces between them. And then to the white blood cells, neutrophils and monocytes, you can see a neutrophil in green, the monocyte in purple, can squeeze between the endothelial cells into the interstitial space or in the tissues. So these are the only two white blood cells that are phagocytic. So that's the next step. So they get into the tissues, and now they can actually perform cellular eating. Neutrophils as well as the monocytes. The monocytes are now referred to as macrophages once they get into the tissues. We also have macrophages already colonizing certain areas of our body like the skin, the liver, the alveoli. So these are going to engulf the bacteria through phagocytosis. Okay. In the meantime, all the cytokines that got released, well, they circulate in the body. Cytokines are like your interleukins, tumor necrosis factor alpha. There's a whole bunch of them. So in regards to a fever response, well, some of the cytokines, which we can call endogenous pyrogens, circulate to the hypothalamus and increase the body's set point, thus raising our body's temperature. As the body will do whatever it needs to do to raise that temperature up. You feel chills, you start shivering, whatever, throw extra blankets on. Now you have a fever, which does improve immune function slightly. Also, some of these cytokines are going to circulate to the bone marrow, so the red bone marrow specifically, and stimulate leukocytosis, so increase white blood cell production, especially neutrophils. And also, we can think about the liver because it does so many things. Cytokines will circulate to the liver and increase C-reactive protein, which is a sign of systemic inflammation or infection. Okay, so that's our innate immune system in a very brief description. So, how do we tie these two together, right? So we have our monocyte, which became a macrophage and engulfed this MRSA. Now, what it does, anything like a macrophage, dendritic cell, etc., it acts like an antigen presenting cell It engulfs that bacteria, destroys it. It can take a piece of protein. So it's a virus. It can take part of the capsid or the protein coating around the virus and present it, put it on its surface. And it's going to present it to something. What's it going to present it to? The adaptive immune system. So that green tube I drew looks awful. That's the lymphatic vessel. So we know any extra fluid and debris gets taken up into the lymphatic fluid or lymph. So we have damaged cell pieces, that stuff's getting taken up, and antigen presenting cells go with it as well, go in through the lymph and enter a lymph node, right? And we know the areas we have different lymph nodes, different congregations of lymph nodes. Now, those afferent lymph vessels are going to bring it to the lymph node. In the lymph node, there's going to be B and T lymphocytes. So I drew two pictures of the macrophage presenting the antigen to the lymphocytes. So there's two pathways here: a humoral mediated, which is the B lymphocytes, and cell mediated, which is the T lymphocytes. So the B lymphocytes, they differentiate into plasma cells when responding to an antigen. But again, an antigen has to be reactive and immunogenic. And if it stimulates the B cells, they're going to converge into plasma cells. Now, there's memory B cells that might have seen this antigen before and respond very rapidly in like 24 hours or so. And then there's naive B cells that have not seen this antigen before. It might take, 5 to 10 days to have a full immune response from this pathway. Either way, B lymphocytes differentiate to plasma cells, and plasma cells start making antibodies. There's 5 antibodies: IgG, IgM, IgA, IgE, IgD. These are referred to as immunoglobulins, or antibodies, or gamma globulins. They're proteins made by plasma cells, not the liver. So there's a bunch of things to know about these. So IgG and IgM are the first two most abundant. So in your initial immune response to something, you usually get a spike in IgM followed by a large spike in IgG. Any subsequent responses, so from memory cells, you get a big spike in IgG and a smaller spike in IgM. Okay. IgG also passes from mom to fetus through placental blood. IgA, we find this in fluids like tears, saliva. It's also found in breast milk, and this is how moms can pass antibodies to a baby, or an infant, I should say, right? Infant or baby. IgE, we just seen that in hypersensitivity reactions, elevations in IgE, and IgD is very minimal amount of IgD in the body and doesn't have much function. Now, cell-mediated T lymphocytes, if they're presented with an antigen, it's reactive and immunogenic, it stimulates them. They can differentiate into two kinds of cells: T helper cells, or CD4 cells. That actually helps stimulate the B cell pathway, or differentiating B lymphocytes to plasma cells, and also can differentiate T cells into cytotoxic T cells, which actually release enzymes called perforins and can directly damage and destroy cells. It's very good at damaging viral and killing viral cells as well as cancer cells. That's it. Last thing, we'll talk about the spleen. Throw the spleen there. It's like a large lymph node. It's in your left hypochondriac area of your abdominal pelvic cavity. What does it do? Well, it's got two areas. It's got white pulp, which contains B and T lymphocytes, responds to antigens like lymph node. That's pretty straightforward. Then the red pulp, this takes up old and damaged red blood cells. Okay, this can take the hemoglobin from old red blood cells. It converts it to globin, which is the protein, and a heme unit, and heme breaks down to bilirubin and iron. And we know the splenic vein flows into the portal vein or hepatic portal vein, and the liver will take the iron up and the bilirubin up, and it can pass it through bile. So if someone has a splenectomy, do they have impaired immunity? Yes, they do, to some degree. So they have a harder time fighting encapsulated bacteria, so they need a vaccine, like a pneumococcal vaccine against Streptococcus pneumoniae, a meningococcal vaccine to Neisseria meningitis, and an influenza vaccine to Haemophilus influenza. But that's about all you need to know.